without further ado, we're going to switch over to health and hear from Jude Harvey.
Okay, right, wonderful. Okay, so I'm going to do my best not to duplicate what Kit and Aninia have already said. Yeah, I am one of 3 health chapter authors as well, but this is kind of pulling together what we've all been working through. So the key issues in revision. Number 1, we are looking at the surveys that were done on how the handbook's actually used. So just being mindful of the fact that there was a bit of a kind of burden of cross-referencing, which was maybe meaning that some bits were being potentially missed in implementation. Also that people aren't cross-referencing between chapters necessarily, and that the standards are often approached as being standalone. So trying to make sure that we're not missing important points within that as we're laying out the standards. As Aninia said, there is a new palliative care standard, which is an interesting one from an evidence point of view, because palliative care is relatively new in lots of settings. The research across the world is limited, and transferability of research and evidence is quite limited. So that's a bit of an interesting one. Communicable disease outbreak. We're trying to have the standards as that could be implemented as a humanitarian emergency itself, not just as a consequence of another emergency. And as Aninia said, that it's Ebola that really springs to mind with that. In terms of the protracted crises, there's obviously lots to think about, but the key areas there really are non-communicable diseases, which is massive, but exactly, you know, looking at what exactly that means, and then long-term lack of access to healthcare. And there is so much work going on with this at the moment from implementers and in the academic sector as well, looking at how you know, how this should work in crises, or how this could work in crises. Resilience and preparedness, obviously within health, the health systems is the obvious section for this. With the sphere standards being used by some governments to put together resilience strategies, there's a few sort of case studies and reports of how it's worked since the previous edition that we're using, and then also within specific standards, so avoiding treatment interruption in non-communicable diseases and HIV and others, looking at systems that exist for that. The sexual and reproductive health, the number of standards has increased, you will see, and that's to bring it into line with the MISP guidance structure and indicators. And then the health systems is still undergoing another round of reviews, looking at the design and presentation of the standards, including indicators and exactly how they work. So that's a kind of rough overview. It's not exhaustive by any means. So moving on to combining expert opinion and other evidence. As is sort of well known, the health chapter and the health sector has a bit of an easier time when it comes to this. There is huge amounts of overlap between expert opinion and evidence, just because of the way the health sector and particularly the medical sector work. However, in terms of the expert opinion, it often has a good evidence base. This comes from case studies, cohort studies, longitudinal studies. The peer review groups were very you know, happy to share where their expert opinion was coming from, and to an extent also in the wider review process. However, it is quite sector dependent. So, for example, the very I've called them kind of clinical specialities, so thinking about trauma really, you have some very good randomized control trials, cohort studies, often coming from the military, that can be extrapolated and implemented in a humanitarian setting. You know, that's very high quality evidence, versus the more public health sector driven fields that rely more on epidemiological data, and actually you would get multiple experts then interpreting the same study in different ways, which was interesting. Reviewers have often referred to awareness of evidence from studies, but but challenges with implementation. So that's, you know, the very ground level things, but also applicability and universality, as Kit said. What we have also tried to work with the experts on is the origins of the practice, that, you know, where did it come from? Was it older guidance? Was it donor policy? Often it's government specific guidance that either has to be implemented or used to have to be implemented. Looking at the review of evidence, we have been finding the current evidence, and that's evidence reviews as well, and taking that back to operational agencies, the academic sector, the private sector, donors, and independent consultants, just to look and get you know, multiple sets of eyes on a study, just to see you know, what the opinions were on individual studies. There is an amount, of course, of working backwards, and that's, you know, from current sphere standards from the Humanitarian Health Evidence Review, and from work from Evidence Aid and Tropical School and multiple others. And similarly with existing guidance documents that, as there a few by coincidence are going under review this year, so just working with their reviewers as well to see what they have in terms of evidence, to look at their interpretation of the evidence. What we are also trying to do, and, you know, to put this out to reviewers, is using published guidance to get indicators. And one of the examples of this is the WHO EMT guidance, using their indicators. Something else that we have stumbled across and has been mentioned in multiple consultations, is the better than nothing approach. So actually, where you maybe have a cohort study or a, you know, potentially a randomized control trial that says that something is, this is exactly how you do it, or this is the percentage to which what should be achieved, and then actually in consultations it comes up with like, well, if we can't achieve this, should we be doing this at all? And that's something that we've been very mindful of when trying to work out, you know, what an actual minimum standard is, and then, as Aninia said, the difference between minimum standards and thresholds, and then what we can put in what will replace the guidance notes, as well. Well, I will talk briefly about challenges, and I know a lot of these will come up later. So number one, there is huge amounts of health data out there that hasn't necessarily been compiled or collated, that could be formed to even if it's crude evidence, it might be evidence that exists. The issues with contextualization, which we will discuss later. The issues with operational feasibility, separate from contextualization as well. The emerging fields such as palliative care, there are limited measurable indicators available in non-humanitarian settings, let alone humanitarian settings. So, and then also this issue of a minimum standard or having some kind of a target, and how Sphere should act, how Sphere could work to make that a kind of a responsible use of that number that does end up in the box, but also indicators that look at quality and appropriateness, which are very important. And the fields that for health that spring into mind are GBV and mental health, but that would extend across all of health, and working with peer review groups, working with people across the sector in how to make sure that indicators that exist for that can be used. So yeah, that's a brief summary of that, and I know there'll be more discussion later. Thank you.
Great, thank you so much, Jude. Really, really interesting, and definitely want to go more into that better than nothing issue that you were talking about, because it raises a lot of questions about, you know, who's driving the production of this evidence. Is it actually answering the kinds of questions that practitioners have?